Hi and welcome to Lessons from the Grand Rounds. So I'm starting a series where I'm going to discuss all the interesting cases which I see uh, every weekly. So in a week, if I see few interesting cases, I'm going to discuss with you. And since they are rare, I'll be just enumerating the brief, small, important points about the topic. So today we are going to discuss about a case of immune effector cell HLH-like syndrome, which is IEC HS. So this is a term um, which is a complication of CAR T cell therapy. So when you talk about CAR T cell therapy, we are very commonly using these for relapse refractory DLBCLs, relapse refractory B cell, um, acute lymphoblastic leukemias. So now similar head to head we have choices, and in the cellular therapies we are performing almost similar number of CAR T therapies as transplant in a lot of frail patients and patients who are who has a poor performance status. We prefer CAR T over transplant because the mortality risk and the um, overall morbidity of CAR T is less as compared to transplant, allogenic transplant. So we have a lot of common to rarer complications post the CAR T cell therapy. So the commonest what we encounter during the first 7 days is grade 1 to 2 cytokine release syndrome, and also ICANS, and then also febrile neutropenia when the patient is cytopenic. Some of them have some prolonged hematotoxicity, so that is why we calculate the CAR-tox, CAR heme score, so hematotoxicity score, and then also decide about the autologous rescue for patients who has increased risk of CAR-T related hemotoxicity. And one of the very rare side effect or complication of CAR T cell therapy is the HLH. So it is said, as per the latest blood paper of how I treat HLH like toxicities, very beautiful paper. I'll be sharing with you if you want. So it has said that the incidence is somewhere around 3 to 36%, and this is usually the time duration is when we have the end of time of CRS, so around day 10, day 15 to the next 30-40 days. So we can have HLH like complications. So let's discuss a case. So this is a 28-year-old female, primary diagnosis being relapse refractory DLBCL. So she was initially treated with R-CHOP and then with salvage chemotherapy, R-Pola, ICE, and then eventually CAR T cell collection and then CAR T. So this patient undergoes CAR T infusion in 3 fractionated doses on day 0, day 3, day plus 3, and then day plus 7. Uh, the CAR T was quite uneventful, with only one complication being febrile neutropenia versus grade 1 CRS, which required only one antibiotic, and the patient was discharged on day plus 14. So this patient after discharge on day plus 14 was following in the OPD every twice weekly, and on day plus 25 on the routine examination, apart from the minimal symptoms of generalized weakness, we saw that there is cytopenias which has developed now. So the hemoglobin was 8, counts were 500, platelets were around 20,000. Very uh, shocking seeing the patient. Patient looked very stable. The patient was admitted for neutropenic care. The event, and then the patient was started on GCSF. Patient 2 days later of GCSF didn't have any improvement. The HLH like markers were checked. We checked for sepsis and the other causes. Smear was good. We checked for HLH like markers where the ferritin from the pre-infusion ferritin, which was just 300, now it is increased to 4,000. Triglycerides are 400. Fibrinogen is low. You suspect that this is HLH. You do a marrow to rule out disease progression as part of as a reason of cytopenia. So you have hemophagocytosis. So this patient is put on dexamethasone for treatment of HLH. Initially, the finances was restricted, so we could not start anakinra immediately. So Dexa was started, then the patient did not respond to Dexa. There was progressive cytopenias. Patient developed fever and a bloodstream infection of E. coli, CTXM, which was treated with meropenem for 5 to 7 days. This patient had progressive cytopenias. After convincing the relatives, we started them her on anakinra with a low dose of 100 mg 12 hourly. So two doses a day, 100 mg. In spite of that, the patient has progression of cytopenias, and then she had uh, a, a episode of hypotension without mounting any fever or any other signs. The Procel was 35. On the VBG, we had metabolic acidosis, lactic letter being 8, shifted to ICU, requiring dual anadrop, escalated to higher antibiotics, more broad spectrum antibiotics, and then patient was weaned off of the anadrops and the O2 support after responding to the antibiotics. Patient also required one session of granulocyte infusion. So this patient, we had increased the dose of anakinra from 100 mg twice a day to 4 times a day, and slowly this patient is recovering from the sepsis. So let's discuss in brief about what immune effector cell HLH cycle syndrome is. So it is a very close differential to CRS or CRS mods, or any bacterial sepsis, or any drug induced toxicity, or uh, TMA like event, or an occult opportunistic infection, or malignancy progression. So in this patient presented by D plus 25. So when you have a period where the CRS is not expected, or the ending of CRS by D plus 10, D plus 15 maximum, you should keep in mind that if there is progressive cytopenias and increase in the HLH markers, so this can be one of the differential, that is IECHS. So this, as I said, the incidence is around 3 to 36%. And what we do basically is we start the basic blood workup. We also rule out viral infections which are cause of secondary HLH in patients who are cytopenic. So we send a good post-transplant viral panel which included all the RSS, CMV was checked. But then everything was negative. We labeled her as IECHS. The initial part of treatment was dexamethasone and then anakinra. The other available options are ruxolitinib, emapalumab, which is not available, and the other is etoposide. So the patient was treated with dexamethasone. The recommended doses are 10 mg per day in the initial part, and followed can be escalated to 20 mg per day. And anakinra, which is actually 100 mg to 200 mg every 6 hourly or 12 hourly. So we started with low dose due to financial status, and then escalated when the patient was not responding. So the other agents which could be tried are Jakavi, emapalumab, and etoposide. So this was about a rare complication of CAR T cell therapy, which is immune effector cell HLH-like syndrome. So if you have any doubts about any other complications of CAR T, you can put on the comments. We'll discuss about CAR T. And this was the first interesting case presentation. I'll be discussing more clinical cases like this every week, and maybe I'll be discussing 3 4 cases in very short period, like 1 minute one case, to save time and to give you more and more interesting cases. Thank you.